When the mechanical integrity of an arterial wall fails, the relentless pressure of the circulatory system forces it to expand outward. This is an aneurysm. This expansion takes one of two primary shapes. A fusiform aneurysm expands symmetrically along the entire circumference of the vessel, while a saccular aneurysm forms a localized asymmetrical outpouching on a single side. Scanning the entire arterial tree reveals distinct geographic patterns of failure. The most common aneurysms overall occur here, in the brain's circle of Willis. In the visceral space, the splenic artery is the most frequent site. Moving down the body, the infrarenal abdominal aorta ranks as the most common extracranial site, and behind the knees, the popliteal artery takes the top spot for peripheral lesions. Anatomy isn't the only variable. When the aortic wall becomes infected, most commonly by Staphylococcus aureus, it develops a textured, highly fragile mycotic aneurysm. These lesions act as physiological time bombs, compressing surrounding nerves and organs, developing internal thrombi, sending ischemic emboli downstream, or bursting under massive systemic pressure. Managing these risks requires looking past the visual abnormality, identifying the anatomical markers and dimensional thresholds, signaling a transition from stability to catastrophe. The goal is to move from reactive emergency care to a system that predicts exact geometric failure points before the first drop of blood escapes. Atherosclerosis drives the formation of abdominal aortic aneurysms, or AAAs. While hypertension is often present, the primary structural degradation begins with atherosclerotic plaque, localizing overwhelmingly below the renal arteries. The definitive screening tool is the abdominal ultrasound, a protocol standard enough to be implemented universally at age 65 in regions like the UK. Clinical presentations vary widely. A patient might harbor a silent, asymptomatic mass, or report a distinct pulsatile sensation in the abdomen, or present with blue toe syndrome as thrombotic debris breaks loose and embolizes into the distal capillaries. Rupture alters the statistics immediately. An AAA typically breaches into the left retroperitoneum. When this happens, the manageable 2 to 3% mortality rate of an elective repair immediately spikes to 50%. This CT cross-section demonstrates the absolute rule of operative planning. An asymptomatic AAA requires mandatory intervention the moment its diameter reaches 5.5 centimeters. If symptoms appear earlier, intervention is immediate. The repair follows one of two paths shown here. Open repair replaces the diseased segment entirely with a synthetic Dacron or PTFE tube. Endovascular aneurysm repair, or EVAR, leaves the weakened wall in place and deploys a stent graft internally through the iliac arteries. EVAR reduces operative trauma, but it requires highly specific anatomy. Difficult aortic access or severe angulation of the iliac arteries physically precludes the passage of the stent. The rigid 5.5 centimeter rule dictates practice. At this exact diameter, the statistical risk of spontaneous rupture mathematically outweighs the risks of major surgery. Choosing EVAR trades the massive physiological stress of open surgery for the burden of lifelong surveillance, primarily because the native aneurysm sac remains intact and susceptible to endoleaks. This schematic highlights a type 1 endoleak. Blood slips past an inadequate mechanical seal at either the proximal or distal attachment points, repressurizing the aneurysm. A type 2 endoleak forms differently. The stent seals perfectly at the top and bottom, but collateral vessels, like the lumbar arteries, force blood backward into the sac outside the graft. This is the most common endoleak after an EVAR procedure. The tanical failures fall into the next categories. Fluid escapes outward, either through a physical defect in the graft structure, a type 3 leak, or seeps directly through porous graft material in a type 4 leak. Finally, type 5, or endotension, presents a frustrating clinical scenario. The aneurysm sac continues to expand dangerously under pressure, yet modern imaging detects no visible leak anywhere in the system. EVAR isolates the aneurysm, but it does not remove it. The pressurized biological environment remains, demanding permanent radiographic vigilance. Moving above the diaphragm into thoraco-abdominal aortic aneurysms introduces a new mapping requirement known as the Crawford classification. This model separates the aorta into 4 distinct Crawford zones. Type 1 begins at the left subclavian and stops at the renal arteries, while type 2 is the most extensive, stretching from the left subclavian all the way down to the aortic bifurcation. Pure thoracic aneurysms carry their own unique risks, driven intensely by severe atherosclerosis or genetic connective tissue disorders like Marfan syndrome. Looking at these dimensional callouts in the chest cavity, the operative thresholds shift. The ascending aorta triggers intervention at 5.5 centimeters and the descending aorta at 6.0. But for Marfan syndrome patients, weaker collagen drops the surgical threshold to between 4.5 and 5.0 centimeters. As these thoracic masses expand, they exert immense mechanical pressure. In Ortner syndrome, the aneurysm compresses the left recurrent laryngeal nerve, causing severe, progressive hoarseness. Above the diaphragm, standard surgical dimensions defer to genetics. Connective tissue strength dictates the timing of intervention. High systemic pressure can force an intimal tear in the aortic wall. Blood rushes in, stripping the tissue layers apart and ripping a distinct false lumen parallel to the main vessel. This is an aortic dissection. Patients present in acute distress, describing tearing interscapular back pain. Clinical signs include sudden hypotension, a measurable blood pressure differential between the left and right arms, and a widened mediastinum visible on a standard chest X-ray. Diagnosis relies on CT angiography for patients with stable hemodynamics, while unstable patients require immediate transesophageal echocardiography directly at the bedside. This diagram illustrates how the location of the tear dictates survival. Stanford A dissections involve the ascending aorta, while Stanford B dissections remain confined to the descending column. The absolute first step in management is strictly pharmacological. Physicians administer a short-acting beta blocker, typically esmolol, immediately. The goal is permissive hypotension to drop the shear stress on the aortic wall. Once the pressure is controlled, the pathways diverge. Stanford A dissections demand urgent surgical thoracotomy to prevent cardiac tamponade. Stanford B dissections are primarily managed medically with strict blood pressure control in the ICU. In dissections, the scalpel waits for pharmacology. Attempting surgery before neutralizing the mechanical shear forces ripping the tissue apart is universally fatal. In the peripheral network, the popliteal artery behind the knee is the most common site for aneurysms. These present bilaterally in nearly 50% of cases and require surgical correction once the diameter exceeds 2.0 centimeters. Femoral pseudoaneurysms operate on a slightly different scale. These are frequently iatrogenic, following arterial punctures, and can be resolved with ultrasound-guided thrombin injection if they remain under 3.0 centimeters. Moving to the neck, carotid artery stenosis has a rigid threshold. A carotid endarterectomy is indicated when plaque occlusion reaches exactly 70%, or earlier if the patient suffers symptomatic transient ischemic attacks, such as transient blindness, known as amaurosis fugax. The peripheral system is also vulnerable to mechanical bottlenecks. Thoracic outlet syndrome occurs when cervical ribs or weak musculature compress the tight anatomical window near the clavicle. This compression targets three specific structures. Arterial compression causes upper limb claudication and thrombosis. Venous compression triggers swelling, seen in Paget-Schroeder syndrome. Neurologic compression compresses the brachial plexus, presenting primarily as ulnar nerve neuropathy. This illustration demonstrates the Ruse test, which, along with Adson's test, relies on provocative mechanical positioning. By having the patient abduct their arms and flex their elbows, physicians artificially tighten the thoracic outlet to confirm diminished radial pulses or induce paresthesia. In the skull, a crysoid aneurysm creates a visible pulsatile swelling of the superficial temporal vessels, usually requiring direct surgical excision to resolve. Central aortic pathology threatens rapid exsanguination. Peripheral disease operates through cumulative ischemia and mechanical strangulation. Surgeons actively create peripheral anomalies for hemodialysis access in the form of arteriovenous fistulas. Before establishing a radiocephalic fistula, a modified Allen's test is strictly required to confirm that the collateral ulnar artery can adequately perfuse the hand on its own. Once established, these high-flow shunts alter systemic hemodynamics. In the Nicoledoni-Brannan sign, manually compressing the feeding vessel suddenly reduces the fistula's high output demand, causing the patient's pulse rate to drop while systolic blood pressure rises. Coronary artery bypass grafting follows strict engineering rules. The left internal mammary artery to the left anterior descending artery is the gold standard, but as this diagram shows, When the great saphenous vein is harvested, it must be physically rotated 180 degrees to prevent its internal one-way valves from blocking forward blood flow. Accessing deep vascular structures requires extensive mobilization. Exposing the aorta requires the Maddox maneuver, rotating the left viscera medially. The IVC requires right-sided rotation via the Cattell-Brash maneuver, and retroperitoneal structures demand cauterization of the duodenum. The consequences of these operations are severe. Cardiovascular failure remains the leading cause of death after AAA repairs. Patients face late-stage complications like aortoduodenal fistulas, localized left colonic ischemia at Griffith's point, or permanent paraparesis if the artery of Adam Kapkevich is compromised during aortic clamping. The physical act of surgical exposure creates a treacherous geography. Controlling a fatal aortic rupture risks paralyzing the spine or necrosing the bowel. High-level vascular surgery relies entirely on a matrix of dimensional and clinical metrics that replace observation with calculated action. This dashboard summarizes core operative thresholds. Abdominal interventions lock at 5.5 centimeters and carotid endarterectomies at 70. Physical engineering limits the options. Flow requires reversed saphenous veins and the Lima-Ladd pairing, while access demands precise visceral rotations like the Maddox and Cattell-Brash maneuvers. Mastery requires mapping complex clinical anomalies against rigid anatomical laws. This discipline transforms variable symptoms into a predictable, algorithmic path toward survival.